Those are 4.
Okay, yeah.
You're looking at 2,500.
How'd you get it there?
Excavator and,
They delivered it, or?
oh, how do you get?
There's some sing-alongs
Oh, yeah,
required
yeah,
with this
my shop.
part, because I'm just kidding.
Oh.
Right, yeah. So we're just gonna go,
My topic,
Right.
choice when she was putting this together.
we're gonna go over some airway stuff. Then we're gonna do some intubations and use the eye gels and talk about, you know, the different types of CPAP masks and all that. So, here we go. Maybe. So what is your airway, right?
Happy?
In simple terms, the airway is part of the respiratory system that allows air to move to and from the lungs. Everybody knows that. So we'll look at some anatomy, right? So the picture on the left is a rough drawing of what we see when we go in to intubate somebody. So the white, you look for the white vocal cord area, and it helps you identify your landmarks when you're in there. Remember that your airway starts at your nose and it goes all the way down into your lungs. Like there's a lot of components to your airway. Everybody can see that, right? Okay. Respirations. Why do we need to actually count respirations? Why is it important? Anybody?
Make sure they're breathing,
Okay, what does it tell? What can respirations tell you?
whether it's labored or they're working at it.
If they have a blue light vomidometer thing.
Yeah,
that's what I said.
So they can tell you sick or not sick, right? In simple terms. If it's abnormal, there's a good chance that they're sick. If it's normal, there's a good chance that they're okay. Normal respiratory rates by age. Newborns, which is 0 to 1 month, they have a respiratory rate of anywhere between 40 and 60 breaths a minute. Infants, which qualifies as 1 month to 1 year, is like 30 to 50. Children, which is 1 to 5, is like 20 to 30. 6 to 12 is 18 to 25. And adults, anybody?
8 to 20.
12 to 20.
Ah,
8's a little slow.
bag 'em.
So an abnormal respiratory rate would be anything outside of the parameters that I just gave you, right? Some reasons for people to have abnormal respiratory rate. Infection is a big one. You see a lot of abnormal respiratory rates with pneumonia, sepsis, those type of things, anything that affects the lungs. But you can also have abnormal respiratory rates with illnesses that do not affect the lungs because they're trying to get rid of carbon monoxide. So they breathe their respiratory rate will increase, they breathe the carbon monoxide out. Lung conditions like asthma, COPD, pulmonary embolisms can raise respiratory rates. Heart problems like heart failure, anxiety can cause increased respiratory rates. Stress, dehydration, there's about 500 million things that can cause it. Some medications can change your respiratory rate. Alcohol consumption, environmental factors like high altitude, bad air quality. It's important to monitor respiratory rates and actually count them. Especially because when you know what normal looks like, you'll be more able to see what abnormal looks like. So a couple of tips to count respirations, because if you're just staring at somebody like this, they're probably not going to breathe how they normally would because they're like, why the hell are you staring at me like that? So pretending to check their pulse for that extra minute, but watching their chest rise and fall while you're holding their pulse is a pretty good one to do. Or if you're watching from like above their head, so you're up in the jump seat doing something, you can count their respiratory rate from out of sight, essentially. So now we're going to talk about different types of abnormal respirations. The first one is apnea. Apnea means no breathing, none. Apnea is a cessation of breathing for more than 10 to 15 seconds or of any duration if associated with bradycardia or cyanosis. Anybody tell me some of the causes of apnea?
obstruction,
Mm-hmm.
opioids.
Yep.
Dead.
Dead is a good one. Hypoxia, hypothermia, anything that suppresses their central nervous system, metabolic disorders, sepsis. Periodic apnea is you'll see that more. People get it with like sleep apnea, but you'll also see it where they have like 15-second periods of apnea when they just stop breathing, and then they just start back up like it wasn't a big deal. Treatment, you're going to treat your reversible. So if they are apneic because they took narcotics, you're going to give them Narcan. If you don't know why they're apneic, what are you going to do? Breathe for them, right? Because they're not doing a very good job. They do say that periodic apnea, like you see in sleep apnea, doesn't cause like the bradycardia or the cyanosis. Just keep that in mind. Tachypnea. What is tachypnea?
Rapid breathing.
Fast. Fast breathing of more than 20 a minute. What are some causes?
Ventilation.
Say it again.
Hyperventilation.
Yep.
Anxiety.
Mm-hmm.
Environmental.
Yep.
High altitude.
Yep. Allergic reactions. Asthma, blood clots, carbon monoxide, COPD, sepsis, cardiac conditions, aspiration, if they've aspirated, and reactions to medications. So our treatment is dependent on the cause, right? So if you can figure out the cause, and if you have the ability to treat it, you can make it better. But if you can't treat it because you don't know why it's happening, how do you support somebody who's got a high respiratory rate?
Coach them to slow down.
Right. So if it's not because of something that's metabolic, essentially, coaching them, reassurance, trying to kind of use distraction. But if it's something, they're tachypnic because they are in congestive heart failure, we could use CPAP, right? So there's a lot of different things that you can treat. No, it's all good. That's I am responding tone. So what does this one mean?
Slow breathing.
Slow breathing, less than what? 12. Less than 12. What are some causes for this? Bradyapnea? I don't even know how to say it. Slow breathing. Kind of the same stuff that we saw on the other slide. Overdoses, lung disease, airway obstruction, brainstem injury, like weak muscles, like if they have muscular dystrophy or stuff like that, you can see slow heart rates. So our treatments, again, you find your cause, treat appropriately. Narcan, that's nice. Atropine. Atropine is one that paramedics can use to increase heart rates. And then supportive. So you either use a BVM or you put them on oxygen and see if that works, or you put a nasal airway in and bag them. CPAP if they're responsive. Hyperventilation is a condition characterized by rapid and deep breathing that leads to an imbalance of oxygen carbon dioxide in the body. Typically that results in symptoms of dizziness, shortness of breath, chest pain, difficulty focusing, fast and pounding heart rate. Sometimes they get a bloated stomach because a lot of the air is going into their belly. Headache, numbness and tingling around the mouth and arms, and cramping in the fingers and toes. And you get an extra point if you can tell me what that's called.
Swan song.
Yeah. So carpal pedal spasms. So they'll get like their fingals kind of cramp up. Their toes will start to cramp up. They get almost like a total muscle cramp in their hands and arms and feet.
What's the cause?
It's because they have too much carbon dioxide. The balance between their oxygen level.
Buildup causes the cramping.
Correct.
And what was it called again?
Carpal pedal spasms.
Carpal.
So carpal, pedal.
Pedal. Too much oxygen?
Yeah, because they're breathing it in. They're so they can't get the carbon dioxide out. I said carbon monoxide before, didn't I?
You
I meant
did.
carbon dioxide.
We let you go with it.
Thanks.
Okay.
They can't get it. It's building up. They can't
Too
get it
much
out.
Oxygen causes. the
That's why they used to tell us to have them like breathe in a bag, right? So they have too much oxygen, and so their balance of carbon dioxide is like this. And so they have you breathe in a bag because then you're breathing back in. It doesn't really work. They say it doesn't work anymore, but
It used to work though.
well, apparently. So hyperventilation happens when you exhale more than you inhale. This is something we see like due to anxiety, stress, panic attacks, fear, but there can be underlying physical conditions that can cause it. So treatment again would be treat your underlying conditions, coaching, removing them from the situation that's causing the panic, if that's what's happening. Purse slip breathing, like they're blowing out a candle, and they have something called box breathing. So you breathe in for 4 seconds, breathe out for 4 seconds, breathe in for 4 seconds, breathe out for 4 seconds. And when they concentrate on that, it starts to slow them down a little if it works. So
Breathe in, hold, breathe out, hold.
that too. Kusma respirations. Anybody know what these are?
Fast and slow or something like that?
So Kusma is actually deep labored breathing pattern, and it's usually pretty regular. Like it doesn't like do the like short breaths, long breaths, short breaths. We see this a lot with diabetic ketoacidosis. So it starts happening when acid levels in your body become too high, metabolic acidosis. Sorry. So your normal pH in your blood is 7.35 to 7.45, which isn't really super pertinent to most of you. Kusmal is actually a form of hyperventilation. Some of the reasons that you can have this are diabetic ketoacidosis, cancer, liver, kidney and heart failure, toxins, alcohol abuse, and sepsis. And again, your treatments would be get them to the emergency room. If it's not just a panic attack, they're going to need supportive care from the emergency room. Hypoventilation, also known as respiratory depression. So you're breathing too slow and too shallow, so then you get a buildup of the carbon dioxide. Hypercapnia is what it's called. So you're not getting enough oxygen in, and so the carbon dioxide is building up. Some of your causes, anybody know of a really prevalent one?
Brain injury.
Could be, but that's not the one I was thinking of. Narcotic overdose. Benzodiazepines slow your respiratory rate down too. Different kinds of medications like barbiturates, sleeping pills.
Okay.
Right, she's got some right there in her pocket. Prescription sleep meds like Ambien. Sometimes they have this, sometimes they get in a car and drive around. Kind of depends on the person. Anesthesia, like waking up from anesthesia. Sometimes people are have a little hypoventilation going on. Obesity, COPD, stroke, hypothyroidism, obstructive sleep apnea is another one. There's a whole bunch of stuff. Spinal cord injuries, nerve injuries, MS, ALS. I mean, the list goes on and on and on. But you can also get it from like a flail chest, from trauma, toxins, poisoning. Treat the cause if able. CPAP if they're alert or responsive enough. Oxygen, mechanical ventilation, Narcan, those types of things. So I've never heard this word but what it means is hyperpnea. I've never heard it called that, so I don't know. Yeah, it's kind of a weird one. This is where the term is where you're taking deeper breaths. It's not so much faster, so they see it a lot with people that just get done exercising or they're exposed to high altitude. They just take bigger, deeper breaths. It's not more rapid most of the time. So some of your causes are exercise, high altitude, anemia, cold air response. So if you walk outside and it's 30 below, right, you take a deep breath like, holy crap, and then it hurts your chest. Asthma, COPD. Usually it's something that's normal and doesn't require any treatment, but it depends on if it's because of an underlying condition. Biats, respirations. What are these? Katie, what are these?
Breathing pattern.
Okay. What happens?
It mimics, like your facades, and it speeds up and slows down, and speeds up and slows down.
So this one is actually where you have the
The pauses.
like you have your rate and depth are typically the same, and then you have a pause.
They
Hold on.
change.
That's Cheyne-Stokes.
No, but these do too.
Right, but it's typically closer together. Like you don't have like the short, then the big, then the short, and then the apnea.
Still change.
Okay. Typically you have that breathing pattern followed by a period of apnea, and then they start doing it again. So anybody know why this happens? Why we have breathing like this? So it's from typically acute neurological disease. So damage to the medulla.
I can't say that word.
I know, but you were playing with it over there. Pons in the brain. So stroke, trauma, severe intracranial hypertension. To treat it, you would assist with ventilations as needed, possibly to the securing of an airway, depending on if they're doing what they're supposed to be doing. Cheyne-Stokes is irregular pattern of breathing consistent of a period of long labored breathing followed by a period of shallow rapid breathing and then apnea. So typically Cheyne-Stokes is a sign of a serious lung, brain, or circulatory problem like a PE, a stroke, heart failure. It also is something that people see at end of life. So hospice patients, they usually do this within hours or a day or so of them dying. We have a couple other reasons. Hyponatremia is one. I didn't know that. I looked that up. I didn't know that severe hyponatremia would cause this. Overdoses on some medications, pulmonary edema, elevated intracranial pressure, congestive heart failure. Again, your treatment is treat your underlying causes. If you can figure them out, provide ventilations and up to securing an airway as needed. So dyspnea, since it's a sensation of difficulty or shortness of breath. Typically it's described as a tightness, like they feel like they're not getting air in and out. It can be caused by respiratory problems, illness, heart disease, obesity, anxiety. This is another one, if it's doesn't have an underlying cause, like all those things on that screen. Reassurance, we can give meds to help. Give meds as needed, whatever's appropriate to treat whatever's happening to them, right? So as you look at this, the one guy that looks like he's pooping in the middle there, what kind of positioning is that? Tripod positioning. So you see him either sitting in a chair, leaning forward, leaning up against a wall, anything to take the strain, like lean their chest forward so they're not having to work as hard. Babies will do it too. Just a lot like that. So tell me what respiratory distress is.
Hard time breathing.
Yes, difficulty breathing. Signs and symptoms would be shortness of breath, rapid shallow breathing. they're having a hard time catching their breath, noisy breathing, so wheezing, stridor, bluish coloration of the skin, lips, or fingertips, chest pain or discomfort, sweating, restlessness, anxiety, confusion. Now we have respiratory failure. So what is respiratory failure? The difference between the two. Respiratory failure is a condition where there's not enough oxygen or too much carbon dioxide in the body. Symptoms include shortness of breath, rapid breathing, confusion, sleepiness, cyanosis. So there's a difference between distress, failure, and then arrest, right? So they have respiratory distress, that leads to respiratory failure, and if you don't do anything about it, it'll lead to respiratory arrest. So respiratory arrest, pretty easy to figure out, right? They stop breathing. So it happens when the respiratory system fails to oxygenate the blood properly. Pneumonia, pulmonary embolism, ARDS. There's two different kinds of respiratory arrest, two different types. So hypercapnic respiratory failure. Anybody?
Too much CO2.
Correct. The system fails to remove enough CO2 from the blood. COPD, so like emphysema, you'll see that. They have that big barrel chest because they have all that air trapping, right? So they get this big barrel chest. And they used to have a saying, it was like pink puffers and blue bloaters, I think it was, because your chronic bronchitis from COPD is the blue one, and then your emphysema was the pink because they're barrel chested and they're because they're trying to breathe all that out. Some of your causes of respiratory arrest, choking, drowning, electric shock, severe asthma, drug overdose, trauma, infections, neurological conditions, heart attack, stroke, all those lovely things. So now I have a question. Which tool do you think is better? Pulse ox or end tidal? End tidal? What do you think? End tidal? End tidal? Yeah? Oh, good. So your pulse ox works, it measures the amount of hemoglobin on your blood, or the amount of, not always just hemoglobin. So it measures what's your blood is carrying in your body. Some of the things that affect readings with pulse oximeters: cold fingers, nail polish, burns, poor circulation, skin thickness, if they have big, thick calluses on their fingers, smoking. An interesting one that I never would have thought of was darker skin tones. Studies suggest readings may be less accurate for individuals with darker skin tones. Another thing is you can get a perfectly good-looking pulse ox and they have carbon monoxide poisoning. So keep that in mind, because the carbon monoxide binds to your hemoglobin just like oxygen does, and it can't tell the difference. Your pulse ox can't. So your accuracy with a pulse ox is typically within 5% of your arterial blood gas values. So it's not so much inaccurate, it's a slower response than your end tidal. So you could put a pulse ox on somebody, have them hold their breath, and it would look pretty good for about a minute if they can hold their breath that long. And then they'd start breathing again, so there's a delay in changes, where end tidal is immediate. You'll see it immediately. Isn't that funny? It made me laugh. End tidal. End tidal works by measuring the concentration of carbon dioxide in exhaled air. So it provides real-time information about their ventilatory status. I wrote down in here about the phases, but I'm not going to go over that because it's a lot of explanation that probably isn't going to mean a whole lot to some of you.
Can you use a capnography if the patient has a nasal cannula on?
Well, the end tidal has a nasal cannula.
So don't they interfere with each other?
Well, you only use, no, they're together. It's, your end tidal has the nasal cannula with that little tail.
Yeah,
You don't put another nasal cannula on.
well, if you have a patient on 2 liters of oxygen, then you add,
Pull it off.
Switch it.
Yep.
Switch it.
Completely switch it
Yep.
from their nasal to the end tidal one with the nasal.
okay.
Yeah, I wouldn't try and put 2 in there. Your normal end tidal values, anybody?
35?
35 to 45. Some of the things that can affect the readings: hyper or hypoventilation, lung disease, pulmonary edema. There was a study not too long ago about how you can use end tidal to see that somebody might be septic, which is kind of a cool tool. Hypovolemia, shock. And like I said, the accuracy of it is, it's real time. So when they change, things change, it changes almost immediately on the monitor. I printed this off for anybody that wants one, because it's kind of an interesting thing to look at, because it shows the different wave patterns for the different issues, essentially. So we can see if we get ROSC on a code by using our end tidal, because we'll have a low end tidal and all of a sudden it'll jump way up, and then you check for a pulse, because typically that's what that means. There's over there, oh wow, that's really small on my computer. The bronchospasm, like an asthma attack, looks like shark fin, right? Your normal ones should look like boxes.
So if you have a patient that you're doing CPR on,
Mhm.
and you got the capnography hooked up on them, and you're bagging them, do you get normal
No.
waveforms?
No.
Why not?
Because, well, look, your cardiac arrest one, I mean, you're gonna get something because you're breathing for them, but it's not a normal waveform, because there's no, like, when you're breathing, like when you're alive and you breathe out, I mean, they're passively breathing out as opposed to actively breathing out, I guess would be the best way to
But they're
explain
still
that.
perfusing, aren't they?
Perfusing, I mean, you are for them,
For
but it's
them,
still, but you're not gonna have that perfect waveform that you would have if they were breathing on their own.
Okay.
So it's
Do you
like,
have a low carbon dioxide number?
typically, yeah, usually, 10, 12, sometimes less. And then all of a sudden it'll jump up to like 20s. And you're like,
If all of a sudden we go, oh, that just changed real fast, we're going to check a pulse, because oftentimes if it makes a big jump from that low number to the high number, it's often indicative. that
Well, when I'm
that's-
bagging, I'm trying to control my rate so I keep the capnography up above 35.
correct.
And if I'm going too fast or too slow,
So tell me, if you're bagging too fast, what does your number look like?
I think it goes down.
It's the opposite of what you would expect.
Right.
So if you're bagging too fast, you're gonna have low numbers on your end tidal. And if you're bagging too slow, your numbers are gonna be high. I don't know if this is gonna play, but we're gonna try it, because it's kinda cool. Oh, maybe.
Welcome to Name That Lung Sound. This is the flashcard game show where you name the lung sound. Let's dive right in. Here is question 1. Can you name that lung sound?
I knew she
Whale slumping?
whales. Okay, what is that? Wheezing.
The correct answer is polyphonic wheeze. This is typically found in asthma and chronic obstructive pulmonary disease, otherwise known as COPD.
I don't know where this accent's from, but it's weird.
Boston.
Sounds like a news director.
Question 2.
Okay. Yeah, everybody kind of agree on that? Sounds like marbles. You're shaking
And the
dice.
correct answer is fine crackles. These are commonly found in interstitial lung fibrosis, pneumonia, and congestive heart failure. Question 3. The correct answer is vesicular breath sounds.
Which means
These are
normal.
normal breath sounds. Question 4.
Sounds like a toilet.
The correct answer is coarse crackles. These are commonly found in advanced interstitial lung fibrosis, pneumonia, and congestive heart failure.
Usually you can hear that without
Question
your
5.
stethoscope. This one's a trick.
The correct answer is bronchial breath sounds. These are normal when auscultating over the central airways, but are abnormal in peripheral auscultation and may indicate a pneumonia, lung fibrosis, lung abscess, or lung collapse associated with a pleural effusion. Okay, let's move on to the next question. Question 6.
What's that one? Strider. Right?
The correct answer is inspiratory stridor, which most commonly occurs
Yeah,
in
right.
children. It is likely caused
say,
by
that's something you're
blockage
not
in
gonna
the
need a
airways
stethoscope
outside of
to
the
hear
chest, in the extrathoracic airways. There are many causes of inspiratory stridor, but the most common in children are croup and foreign body aspiration. Let's move on to question 7.
Pleuris.
The correct answer is rhonchi.
Oh, I was wrong.
Rhonchi are common in bronchitis
Sound
and
like-
pneumonia.
There it is.
Question 8.
There's a wolf. Or a cat.
I like that one.
The correct answer is monophonic wheeze.
So it's
It is
just a
caused by
diffuse.
obstruction of a single airway, and the obstruction may be due to secretions, foreign body, or tumour.
So I would have called that an expiratory wheeze.
Question 9.
There. Snoring, right? It does sound like snoring. Yep.
The correct answer is pleural friction rub, and this is typically heard in the presence of pleurisy and pleural tumours.
Sounds like growling. All right. So I put this in here to talk about your guys' scope, but we really don't have to do that because I feel like y'all know what you can do and what you can't. But remember that you have a lot of tools for airway support at every level. Few different medications. You have, oral airways, nasal airways, eye gels, CPAP, BVMs, non-rebreathers. I mean, there's many, many options. So I just in there talked about. So now we'll talk about non-visualized airways. So those are the ones that at an EMT basic level you could use. But I wanted to show you where they've come as a. Anybody name that tool? Nope. Combi. It's a combi tube. That was this one. That's a king. And this one. Okay. And that one.
The female catheter.
Close.
Element.
An LMA,
What is an LMA? Is that,
laryngeal mask airway. So it's like the iGel is like an updated version of an LMA.
so the LMA has been around for a while?
Yeah,
The LMA is what they use a lot of times in your surgeries.
yeah.
They just need to go in and sit, you're not gonna be moving them or doing anything like that. And it's not designed to be an emergency area, but it's often used in like your,
OR.
OR. Yeah.
What's the little thing coming off of it?
You inflate, it's an inflatable cuff.
Was it inflatable? Okay.
And the iGel just has the gel,
Squish.
the squish. So these are nasal airways. And then oral airways. Talk a little bit about CPAP. CPAP is considered a non-invasive ventilation. How it works is it delivers a continuous stream of air. So CPAP, continuous positive airway pressure, right? And it helps keep your airways open and improve your gas exchange down to your alveoli. Typically what's happening is your alveoli are collapsing when you're exhaling. And so CPAP is going to help force those alveoli to stay open so that you can breathe a little better and have better gas exchange. So its purpose is to improve ventilation, reduce your work of breathing, reduce intrathoracic pressure. It decreases the workload on the heart too. That's why it works so well for congestive heart failure. It does that by decreasing your venous return and your preload. So, they can't breathe. What do we do? Your indications for visualized or non-visualized air intubations and CPAP. So your indications for visualized intubation. So at a paramedic level, we use the laryngoscope. Some of your indications are the same for both, right? Respiratory arrest, respiratory failure, airway obstruction, cardiac arrest, inadequate oxygenation or ventilation, or protection from aspiration. They use that a lot more in the hospital than we do because we typically try not to aspirate people. Non-visualized airway is a little more strict in a basic level because you guys can't take somebody's airway away. Like you can't give them meds to stop their breathing. So you can really only use it for cardiac arrest or respiratory arrest. And CPAP, indications for CPAP would be respiratory distress, congestive heart failure, bronchoconstriction. They said toxic inhalation, which I thought was interesting, and drowning, because it helps push that fluid out. What are some of your contraindications? Alert and talking? Yeah, that would definitely be a contra. Don't try and shove a tube in everybody that's talking to you. But laryngeal edema, because everything's all swelled up. You won't be able to see anything. Epiglottitis, which we see more in kids. Essentially, epiglottitis is if you even blink hard at that epiglottis, it's going to swell. So you just try your hardest to let them be. Severe upper airway obstructions, nasal and jaw fractures, and facial trauma is a contraindication, but only because they probably will need a trach instead. Because if they're all smashed, you're not going to be able to get an airway in typically. Significant bleeding disorders. Sometimes they say, because it's traumatic when you're intubating somebody, that if they have a bleeding disorder, you could cause bleeding because the tissues in your airway are sensitive. What is your contraindications for CPAP?
They can't maintain their own, they're not able to
Follow commands?
yes.
Okay, I figured that's what
Yeah,
that meant.
I'm trying to.
What else?
Facial trauma.
Facial trauma. What else? Are you going to put a CPAP on somebody with a pneumothorax?
Sure, why not? Let's blow it out.
Make it bigger, make it worse. What about blood pressure? Is that hypotension a contraindication?
Yes.
Because what does CPAP do? Other way. CPAP will drop their blood pressure,
It'll increase the intrathoracic pressure.
right,
So it has to be over 100 to stop?
typically. Also, they need to be responsive. You can't put CPAP on somebody who is unresponsive. I talked a little bit about some of the tools that paramedics use because a couple of you work with medics, so I figured I'd bring it up. So a bougie is the middle row all the way to the right. It's a intubation tool, helps get an airway, a difficult airway. Some people use them every time. Some people only use them if the airway is going to be difficult. Wonder what happened to the rest of that word. The laryngoscope blade is your top.
It's under the picture here, but
Yeah, it must be. So the top left, so those are Mac blades. So the Mac blades have a little bit of a curve. And then the middle picture is a Miller blade. Miller's straight. Your ET tubes down on the bottom right. They also have a stylet in that picture. 10 ml syringe because you inflate a balloon on an ET tube, so that's up in your top right. The suction, portable suction on your bottom left. And the ProView is the laryngoscope that we use, the video laryngoscope we use, and I'll show it to you when we go out there. But it shows us what we're looking at on a screen. Any questions? Anybody have any discussion? I know that was a lot of information, but it was a review, right? All right, well, let's head out to there, and we've got some stuff to play with. The garbage